Welcome to the Back to Movement podcast. This is your host, Bernadett, and today's conversation is all about chronic back pain, a condition that affects 619 million people globally and remains one of the leading causes of disability. It's not just physically exhausting, it can be emotionally and mentally draining too. But the good news, there's so much more we can do to help people truly heal. I'm joined by Professor Peter O'Sullivan, specialist musculoskeletal physiotherapist and the John Curtin Distinguished Professor at Curtin University in Australia. He is internationally recognized as one of the world's leading researchers, clinicians, and educators in musculoskeletal pain, and the pioneer of a new whole-person approach to recovery. In today's episode, Peter helps us understand why changing the story we tell ourselves about pain is one of the most powerful steps we can take, and why many of the messages we've been given about back pain are outdated or even harmful. We'll also explore the common myths still holding people back, why scans often do more harm than good, what needs to change in how we treat and talk about back pain, and how a more evidence-based, whole-person approach can actually give people their lives back. This episode is packed with insights and potentially life-changing information for anyone living with chronic back pain. Pete, thank you so much for accepting my invitation to the show.
That's a pleasure.
I am incredibly excited to have this conversation with you.
Yeah, thank you. I think you've done a great, you've kind of summarized our work now. we could almost stop it at that.
We can finish right now. Now, Pete, can you explain what you mean when you say that we need to change the story about back pain or pain, and why that's such a critical piece in helping people recover?
Yeah, so there's lots of research that's looked at what population beliefs around back pain are. So if you go into the community and you ask young people, middle-aged, older people, what's your understanding of back pain? Or if you ask healthcare practitioners, what's your understanding of back pain? The general discourse is that, back pain means there's something damaged in your back. You need a scan to identify it. If you've got pain, it could get worse. It could disrupt your life. It's a sign of damage. You need to protect your back if you have back pain. So there's this general discourse that the meaning behind back pain means there's something damaged. Because of that, you need to get a scan to identify the damage. You're either going to fix the damage or protect the damage. And that sets up a whole mindset around back pain as something that is not modifiable. It's something that needs to be fixed. And that creates an emotional response, often fear, distress, sadness, like a sense of loss of the things in life that you value, because all of a sudden it's like, be careful when you lift, be careful you bend, you can't go and do the stuff you love, you shouldn't run, you shouldn't lift over 10 kilograms. There's all this kind of information that drives negative emotions and behaviors. So behaviors around overprotecting the body, guarding the body, becoming hyper vigilant around the body, and all the rules that kick in that we perpetuate in society around have to brace your core, keep your back straight, don't, bend with a round back. So this is kind of, what we would call a discourse of negativity and overprotection that has, permeated the whole situation around back pain around the world. And it's not specific to country. It's a general discourse. And that perpetuates people down pathways like trying to fix the problem through surgery and injections and, the opioid epidemic that you are fully aware of. It's become an absolute disaster. And it's not evidence-based. that's probably the saddest part, is actually we're hurting people because of the things that we tell them and the way we treat them.
I often imagine pain like a smoke alarm. It meant to protect us, but
Yeah,
sometimes it goes off because, like a
yeah,
smoke alarm, there is
yeah,
burnt toast and the smoke alarm went off.
yeah,
When we are tired, stressed, or not coping
yeah,
well, even
yeah,
small things can set off our
yeah,
pain system. Am I
yeah.
correct?
Yeah, 100%. And look, that's the tricky part for a healthcare practitioner. You could have your smoke alarm go off because you've got an infection or a fracture or a malignancy or some kind of pathology in the back. But the smoke alarm could also go off because you're stressed and tired and run down. You're anxious. You've not been exercising as much as you
Mm.
should, or there's stuff happening in your life. Your life's in chaos. The problem is it doesn't differentiate between chaos in your life and pathology. And so the job of the healthcare practitioner is to make sure you rule out serious stuff, which is the minority. We know it's about 1% of people in primary care who have serious pathology, and it's around, 5% who might have some kind of like a disc protrusion that is affecting a nerve, like a radiculopathy. The vast majority of back pain is not linked to pathology, not defined by pathology, but we pathologize it. And that means that what is a stress related or tension in the body or inactivity or whatever else is happening in your life, then you start adding another burden to that person of going, well, it's not just stuff happening in your life, you've actually got a problem with your back as well. And I
You
think we
tou-
get it for headaches. We
eh,
understand that you can have a terrible headache because you're tired and run down the stress. You can also have a terrible headache because you got a brain tumor. And you could also have a
eh,
terrible headache because you got a brain bleed. But that's why you have skilled clinicians who can differentiate between the two.
and you really touched based on something. I had my yearly checkup last year in November, and I'm based in Dallas, Texas, and out of curiosity, I asked my primary physician, so what do you do if you see someone with chronic or with back pain? And she told me she can't deal with the person. She straight away, send them to the specialist because they cannot prescribe strong medication. And I was literally
Yeah.
shocked. I was
Mm.
almost falling off my chair because I know the clinical guidelines.
Yeah.
We know the clinical. You just need to rule out the red flags, right?
Yeah.
Cor
That's right. Yeah.
equina, cancer, fracture,
Yeah.
where cancer
Yeah.
is tricky in
Yeah.
primary healthcare, but did you fall in the last 2 weeks, or asking the right questions?
Exactly. Yeah. Good history taking is so important. Yeah, but
Exactly.
but but
Uh,
I think the most important thing is we mustn't miss it. But it's literally 1 in 100 of people that you might see.
yeah.
So
I
so we mustn't miss it, but we mustn't frighten the other 99.
Yeah. Now, there are clearly times when pain is a useful warning signal, like with a
Yeah,
fracture or a
yeah,
serious injury, a car
you
accident,
bet,
where
you
protecting
bet.
the area is important, but most
Yeah,
back pain isn't that. How many percentage?
exactly.
Probably 93% of back pain isn't serious, right? Am I correct?
Yeah,
Something like
yeah,
that.
yeah.
So,
It's serious. It's a serious problem for the person, but it's
ex-
not serious as in pathology that's driving it.
yes,
And I think that's the important thing to differentiate. It's seriously disruptive, seriously disabling, seriously distressing, but it's not like there's an underlying pathological process that's driving it.
yes, and I definitely agree with that because I had my mom who I was probably about 13, 14 when she started to have chronic back pain, and she could not get out of bed for weeks,
Mm,
days, and then
mm,
she even missed my graduation because she had a surgery which didn't work out.
mm,
She wasn't in good hands, unfortunately.
mm,
But her back pain went away even after unsuccessful surgeries, and now she's physically active and lifting weights and squatting with heavy weights,
mm,
which is amazing.
mm,
But the thinking changed since I do what I do.
mm,
It's
mm.
she's more confident in her body that there is nothing
Yeah,
wrong. Maybe I have a bad day, I need to take it easier because I
yeah,
woke up with some sort of back pain, didn't sleep well, there is a lot going
yeah,
on. I
yeah,
just take it easy and I know I'm safe and I'm gonna be fine. But
yeah.
many people think that just because they are in pain, oh, there is something
Yeah.
wrong, I need to have an MRI,
Yeah.
and
Yeah.
they find disc degeneration or disc herniation.
Yeah.
But we know that
Yeah.
research shows that even pain-free people have
Yeah.
those
Well, most pain-free people have those. So, if you look
as
at
we age.
well, yeah, but even at the age of 21,
Mm.
I think there are studies showing at the age of 16, about 30% of people have disc degeneration. At the age of 21, it's 45%. That increases to 60%, 68% when you're 40, and then almost everybody's got it after that. So these are just normal age-related changes in people. Now, there is some evidence that if you have a number of those changes in early life, so a bit before the age of 40, you have an increased susceptibility to back pain, but it doesn't predict how disabled you are or how much pain you feel. Those are influenced by other factors, which no doubt we'll talk about today. It's about how you respond to pain, how you think about the pain. And I would see this similarly to something like heart disease. You could have a genetic predisposition to heart disease, but if you smoke and if you are not active and if you're overweight, and if you're stressed and not sleeping, those risk factors become so much greater that increase your risk of a heart attack. If you manage those risk factors really well, you reduce your risk of a heart attack. So in the same way with pain, this interaction between structure and all these other lifestyle factors is you can reduce your risk. And so that's how we would look at it, is like, what are the drivers? That's a lot of what we do in our research, is to say, what are the things that set people up to become disabled? And disability is the big issue, right? Because it's people can live with pain if they're doing the stuff in life they love and they're engaging with things in a meaningful way, and the pain is not a threat to them. It may just sit in the background as something that pops up from time to time. It's really just a message to say, hey, care for your health. When it becomes profoundly disruptive, it can just affect every aspect of your life. And you no doubt saw that with your mum's situation as well. A
Yeah,
horrible
absolutely.
situation.
Yes. Now, you've talked a lot about back pain isn't usually caused by a single injury or weak muscle, right? I mean, we know
Yeah.
that. So let's go there. What actually contributes to back pain or chronic back pain?
Well, they're two different things. So one is a back episode. So we know that most people have an episode of back pain in their lifetime. It's as common as a cold. Like almost everybody will have some back pain. If you look at the things that trigger it, it could be some unaccustomed movement, sudden loading of the back. But usually you're most vulnerable when you're fatigued and you're tired, you're under stress, you haven't been as active, and you do something that you're not accustomed to. Now, the majority of those back pain episodes will subside in 2 weeks. Like you look at the natural curve, the majority get better. There's a small group of around 20%, sometime, in some cohorts up to 25%, where that pain persists. So that means the back pain may emerge. It may emerge from a simple sprain, or it may emerge at a time when you're stressed or run down or whatever. There's a group where it becomes persistent. And if you look at the evidence as to why, it's not pathology. It's more like, oh my God, I've got this back problem, starting to worry about it. So you're starting to think of these, catastrophic thoughts around, oh my God, I've got a back problem that may not get better. You start to get worried. You start to become frightened. You start to overprotect the body. You start to avoid stuff. You lose confidence in your body. That sets up this kind of complex process within the nervous system of overprotection. So protective muscle guarding is what we see. You start moving slower, stiffer, more guarded. You start avoiding stuff. You start becoming hypervigilant. You start becoming worried. You kick in your stress system, which may have already been kicked in prior to the event, but that ongoing stress response, which drives, protective behaviors, hypersensitivity in the body, and it sets up a vicious cycle. What we would say a vicious cycle between, these negative perceptions, these unhelpful emotional responses and overprotective behaviors that just create this cycle that perpetuates itself. And so given these are thoughts, emotions, and behaviors that are drivers, they are the things we target to kind of reverse the cycle, I suppose.
Okay. So many people think they get injured by putting their shoes on or
Yeah.
reaching for the remote control in a wrong way, or
Yeah.
can
Yeah.
we talk about that a little bit? Can
Yeah.
that
So it's a
happen?
really, yeah, you bet. Well, not injured, but you can create you can develop back pain. You can have a back pain episode bending over to pick something up, for example. But I would say to that person, how often do you bend over to pick up your shoe? They're like, well, I do it every day. So why yesterday? What
Mm.
happened yesterday? That, and for a lot of people, it's not even that. It's just like I woke up and I have terrible pain. It could come on for they can't even think of a reason. We know that's common as well. Usually, when you start exploring what preceded that, there's a period of increased stress, less physical activity, poorer sleep, that, mental health is poorer. We know those things set the body up, that maybe the body's more tense, more sensitized, more susceptible. So the putting on the shoe is just a trigger for what was a kind of an environment of vulnerability. And, we often use the analogy of you light a match in the forest on a wet, damp day, it fizzles out. But in Western Australia, if you light that match in a hot summer day with a wind blowing, it turns into an explosion. And so it's not the match; it's the environment that is the key. And that's why we have to explore what's happening in that person's world. Now, that's not to say you can't fracture your back. When I've had a spinal fracture, I've had a disc protrusion before, but I've also had pain from I've had from no injury as well. And probably the no injury pain was the worst pain I had. They are different drivers of pain. And I think as long as we understand that from a clinical perspective, we need to explore for those things, because then it starts making sense. Because it makes no sense that you bend over and pick something up and your back spasms and you can't move. It doesn't make sense from a structural point of view. It makes sense when you understand how the nervous system operates.
So it is kind of like your cup got full. We have the cup of resilience, right?
Yeah, you bet.
And we pour in some
Yeah.
anxiety, depression, low
Yeah, you bet.
self-efficacy.
Yeah.
And then the cup overflows with that one little
exactly.
move. And that was
exactly.
just the last drop, and the cup overflows, right?
Yeah, exactly. Yeah.
Okay.
And the key thing with that is if it is that the person is, being stressed and run down and, not as active, the worst thing you can do for that person is rest them. It's the worst thing you could do is to say, well, you got to protect your back. Oh my God, now you got this terrible back. And that just ramps their stress levels up. You then take away the very things that protect them from managing their whole health. We know that people, when they're in pain, they tend to avoid movement, they avoid socialization, they don't go to work. All the things we know that protect our health. We tend to eat poor, we might drink more, we might reach for, drugs that actually don't help us in the long run. So often our reflex, and it's a natural human response, is to do the things that actually perpetuate the problem. And often healthcare does that as well.
But I have to be honest with you, when you have excruciating back pain and someone is telling you need to move, it's like, I can't move.
So,
why do you tell me that I need to move?
Yeah, look, we wouldn't do that. So in a clinical situation, we would explore what the person's doing, just teach them to relax. So, there are ways, often what people forget, it feels very invalidating to say, there's nothing damaged in your back, just get moving. That's not a validating thing to do. To understand that those structures are super sensitive, highly sensitized, and the body's in protective mode. That's why through a therapeutic process of validating the person, listening to them, understanding their distress, teaching them to relax, and then gradually building the confidence back in the body to re-engage with movement actually gives pain relief. So
Mm,
it's not like you're just forcing someone to move
mm,
with excruciating pain. You're giving them strategies to take control of their body, to build their self-efficacy, to take a sense of ownership back that actually gives them pain relief. It reduces their
mm.
distress. It builds their confidence. So that's a really important therapeutic process that I don't think many practitioners believe you can do. That's where there is a role in some situations for hands-on therapies to just help to relax very tense muscles in that phase to build the confidence back to go, hey, if we get you relaxing and we get you moving, actually you're going to feel heaps better.
Yes, but hands-on therapy alone isn't helping
Not for chronic
the
pain, and I
patient.
think that's the key thing here. The majority of acute pain problems get better on their own if we do nothing. For chronic pain, that's the area we've been interested in. It's a way more complex process because you've already got these factors that are interplaying with each other, and that's why passive therapies of any variety tend to be not effective for long-term change. And we see so much evidence of that, of people who've literally gone back and back and back for lots of hands-on treatment that gives them literally, if you're lucky, a day of relief, and then they're stuck on that same trajectory. And that's why I moved as a manual therapist to broaden my way of working, because I realized that my manual therapy skills weren't sufficient to shift the trajectories of those patients.
Mm-hmm. So if someone got chronic back pain for 5 to 10 years,
Mm,
whatever,
yeah.
that means their body got used to the pain, right? And is it
Yeah, yeah.
because of that it's really hard to get actually rid of that experience,
Well,
or no?
yeah. So, with our research, we've captured we've done single case experimental research with people with like 8 out of 10 pain. And look, I'll give an example of a young person I saw this week. She came in with 8 out of 10 pain. She's like in her early 20s. She's had it since the age of 10, highly distressed, a
Mm,
lot of complexity. But within a single session, her pain went from 8 down to 0 within a single session, just through, this therapeutic process we can talk through around listening, validation, um, uh, reconnecting her to her body, but giving her an awareness around her overprotection, giving her strategies to relax and building confidence back to move. Often you'll see huge shifts, not for everybody, but for a lot of people, you'll see very quick shifts in terms of a change in their pain levels and their levels of function within a single session. And that's what we use, what we call behavioral experiments. So we'll use these behavioral experiments to say, so what are the things that you're frightened of? So for her, it was bending, lifting, jumping. So we explored what she was doing, like, so she's overprotecting, she's bracing her
mhm,
core,
mhm,
she's breath holding, she doesn't have good awareness of her body, of bringing that awareness back, realizing that actually she has all this control that she didn't know that she had, dials down her distress, reduces her anxiety, builds a sense of trust, and you'll see pain change really quickly. And we've documented this in a number of studies showing that you can take someone who's got really severe pain and disability, within a week, they can change.
mhm.
And the Restore trial showed within 6 weeks, you'll see the biggest shift in a person. And then it kind of tails off, but it can improve, up to 12 months later. Um, so not for all, but for a lot of people, you'll see quite dramatic shifts within a single session.
You mentioned 6 weeks, but so back pain has a natural history of 6 weeks as well, right?
Not for chronic back pain.
Not for
So
chronic.
for
Oh, yeah, that's
no,
right.
no. So for acute back
So it
pain,
flare up, yes.
yeah, but for chronic back pain, the studies have looked at people 1 year, 5 years, 7 years, showing that trajectory doesn't change. So for the severe group, there's a group of people who just get stuck,
Hmm.
and they'll bounce around that kind of trajectory, stuck. That's really
Hmm.
different than acute back pain. And a lot of people probably go into clinical trials with an acute flare up of back pain that then kind of they track, then that settles down and they go back to their baseline. So I think the key thing is to go, what is your baseline and can we change that baseline?
Mm. Have you experienced that with any of your patients that they started with back pain, but then after a few sessions, the pain traveled to somewhere else, like a shoulder, a hip?
Yeah,
Because I
totally.
experienced that with
Yeah, totally. Yeah,
my
yeah,
clients, that sometimes, we
yeah,
start with back pain and the back pain got better in 2 months.
yeah.
And then now the right shoulder is hurting. Can we
Yeah.
talk about
And
that?
I think that usually reflects that we haven't addressed some of the underlying drivers of pain sensitivity in the body. And so, the person may have, may be very stressed. They may have a stressful job or a stressful home life. They may not be sleeping well. So, it's almost like we get these spot fires that pop up in the body, in different places. And so you
Mhm.
settle one down and they pop up somewhere else. And that's more of a systemic sensitivity where it's like, you'll see that with widespread body pain, where the person's, neck pain, back pain, knee pain, shoulder pain, hand pain, foot pain, like everything's hurting. And one thing improves and the other thing, it's like the body just puts a spotlight somewhere else. But that's to me a sign that you've got to look to the whole system. There's something dysregulated around the nervous system when that's happening. And so we're chasing around the body, but maybe not addressing some of the central issues.
Mhm. Now you mentioned that you have a client and maybe they have something going on at home, stressful work.
Mm.
What do you tell those patients?
Yeah.
What's your strategy? What do you do?
Yeah, so we're lucky in that in our practice we have a psychologist who we work with, and so one of the things that we explore, and is tell me about your life. What's happening in your life, and so you start hearing things like, I've got a partner who's with mental health problems, and um, it's uncontrollable, and had a person yesterday, and she's got a child at home with major mental health problems who is, not coping well. She's caring for two grandchildren. She's got another child who's unwell. She's just carrying a huge amount of stress. And so part of my discussion is, how much do you think that's influencing your pain? Because we're not going to tell them. We ask them, and they're like, yeah, I'm not sleeping, I'm feeling stressed all the time. So what are
Mhm.
your stress coping strategies? How are you managing that? And so exploring things like, you engaged in regular physical activity? Are you got other social networks? Are you doing fun stuff? The things that we know protect us against stress. Are you using any breathing meditation techniques? Are you kind of writing those thoughts down in a diary? Are they working for you? And if they're not, do you think it would be helpful if you talk to someone about this? So we kind of open up that whole box to go, what are your resources? What are the things you're doing at the moment to cope with that stress? Because it's a big thing. Um, and then, do you think you need additional support? And if they do, that's where we cross refer to a psychologist to say, let's just
Mhm.
see if we can help you manage that better. And that's a cool thing, within our clinical setting, that I'd say the minority we would use the psychologist, because a lot of what we're doing, the stress is linked to the pain itself. But where there are external stresses, or there's a history of trauma, early life trauma, or recent trauma, comorbid mental health, we're making sure that we're caring for the whole person.
We didn't talk about weak core causing back pain, Pete.
Yeah, no, there's really no good evidence for that. The
I
core is
trick you. I
interesting.
trick you now.
Yeah, yeah. The core is interesting because it's good to be strong.
Mm.
Um,
Physical
it's,
activity is good.
yeah, really important, and it's important to be strong. And so, we have these discussions with patients all the time, and they go, "Oh, I think it's because my core's weak, and that's why I have a back problem." And the problem with that thought is that people end up over contracting their core. So what's the core good for, right? So we go, what is it good for? It's like saying it's good to have a strong hand grip. You need a strong hand grip to pick up a heavy weight, but you don't want a strong hand grip when you're writing. You want a soft hand grip when you're writing, because otherwise you get writer's cramp and it's very painful. In the same way with the core muscles, they're good for sit-ups, they're good for push-ups, they're good for planks, they're good for pushing, they're good for controlling your body over your head. If you're hitting, tennis racket, you need a strong core to drive the ball. But they're not good for sitting and standing and for lying and for bending or even much for moderate lifting. There are studies showing that even a maximal lift, you're only working 30% of your core. But what we see with people with pain is they're sitting, engaging their core, they're standing, engaging the core, they're engaging the core when they bend or they lift, or they're over activating those muscles. The problem with that is that creates increased co-activation of the muscles around the body, which we know people with pain already do. So, it's like this, it's like we're reinforcing more protection in the body in an abnormal way. And that's no different than walking around all day with a clenched fist saying, I've got a sore wrist and it's really stiff. And it's like, well, actually, if you relax your hand and move your wrist, you'll see that there's freedom and it feels good. Preserve your clench for when you need it. With the back, we often see people are hyper vigilant and overprotecting and over guarding using their core muscles, and yet they may test weak. So, it's like any muscle that you're working all the time often will fatigue rapidly. So it's it's being used for the wrong job essentially. But that's a
So,
really common thing we see, which can become really unhelpful.
so this is a myth, right? We don't need a strong core. I mean,
Look, you need a strong core to do push-ups
but it
and
doesn't protect us from having a back pain.
no, it doesn't. We know that. Yeah,
But
yeah,
this is going around everywhere,
yeah.
social
It's huge.
media,
Well,
everywhere,
I think
Instagram,
yeah,
everywhere.
yes,
Core.
it's
There is
yeah,
even core balance training for
yeah.
chronic back pain.
Yeah, it is. And look, I think it taps into social desirability because we have this view of the human body. It's got to look a certain way. We've got to hold postures a certain way. That idea of social desirability of like, you want a flat belly. We teach kids this, it's through society. So it's kind of latched onto that, and then there was a whole movement around suck your tummy in to
Mm,
activate your corset.
mm.
Like it's created it's been really unhelpful because it tells people you need to protect your vulnerable back. We don't do it with any other body part. We don't pre-tense your quad before you bend or pre-tense your biceps before you flex your elbow. It's just, it's just one of those really unhelpful things, which, has kind of hooked into that sense of social desirability. It's been picked up through the kind of health industry. Like we give core exercises to get people strong to do the things in life that are important for them. If you're pushing a pram up a hill, you need a strong core. Like, but
I-
you don't want to have those muscles engaged when you're bending over and rolling in bed and getting out of a chair. It just isn't helpful.
you just make me laugh. So, now, Pete, and even if you think about it, you suck your belly in and you think you're gonna protect your back. Like
So
honestly,
you tense your back.
exactly.
All you're doing is tensing your back.
Yeah.
You're
So
not
it
you're not
doesn't
protecting
protect
it.
you. Yeah. Yeah.
No,
Yeah.
actually, it loads you more. So what we know is that when you suck your belly and you co-activate the muscles around your back, creates more load and stiffness. And we do this with clinicians where we get them to practice to just go bend forward, bend backwards, side bend, twist right and left. Now do it where your core's activated, and you can feel you create all this stiffness in your body.
Mm,
Now, stiffness might be helpful if you're lifting a really heavy load, but it's
mhm.
not helpful if you're doing that day in, day out, moving and twisting and reaching for stuff. That could increase your susceptibility, restricts your movement, increases load on what might be pain sensitive structures, and it may perpetuate your problem.
I actually used to
It's
teach.
not normal.
I used to teach Pilates like that 15 years ago. Suck your
Yeah,
belly in before the movement. Why do
I
you
did
need to do
too.
that before
I
the
did
movement?
too. I did too. So, back in when was it? The 90s, that was the thing that we published research looking at it. And, I realized very quickly clinically that actually people were becoming stiffer. Where people who were already stiff were becoming stiffer. And they were like, this is not helping me. This is making me worse. And we're like, oh, hang on a second, what's happening here? And that's just because we have a belief. We come to most things in our life with a certain belief. And the beauty of the work we've been able to do in our research is to test all these beliefs and go, actually, are they well founded? And if you look at the EMG studies of people with pain, they move slower and stiffer and they're usually more guarded. So why are we teaching people who are already stiff and guarded to be stiffer and guarded? Doesn't make any sense.
No, we need to teach them how to be more confident in their bodies and to
Relax.
move
Yeah,
fearlessly.
the
Yes,
best back is the back you don't think about. And I often say
exactly.
this to a patient, when did you last think about your elbow? And they're like, I don't. Have you got a problem with your elbow? No, I don't. Well, I don't want you thinking about your back. I want you to have a back you can trust, that you don't need to think about, that you can just do the stuff in life you love. That's a good back.
Yes, you drop something and you don't need to think about it. How am I going to pick this up? You
Exactly.
just do
Yeah.
it.
Exactly. Yeah. Yeah.
Now let's talk about posture, another favorite
Yeah.
topic. So we've been told for years to sit up
Yeah.
straight,
Yeah.
avoid slouching, and keep your
Yeah.
good posture to
Yeah.
prevent pain.
Yeah.
But
And so
there's
again,
research says
yeah.
otherwise. So can we talk about
Yeah.
that? Why do you think that there is a belief
Yeah.
that good posture saves you from back pain?
Yeah.
And what's a
It's
more helpful message when it comes to
yes.
posture and
Yeah.
pain?
So this is the whole social desirability thing again. What looks good? We have in different cultures, we have a view about what looks good. It looks good to be upright and have, we have these kind of beliefs around what should look good. So, we have these grids where we line people up and go, oh, this posture's bad and this posture's good. And, it's another trap. What we know about the human spine is that it loves movement. A healthy back is a back you move. So being sedentary is not good for any body part. Using your back, moving your back is really important for the healthier spine. So this idea that there is a perfect posture is just not informed by the evidence. There are systematic reviews that have looked at people with pain and without pain to go, is the people with pain, if it was like that, you would see all the people with back pain have slouch postures and the people without back pain have good postures. It's not what you see. So we did a study looking at young people, like about 1,200 young people, and we looked at the slouches and we looked at the ones who sat upright. We know the biggest predictor if you sit slouched is if you're male. So boys sit slouch, girls tend to sit more upright, probably because they've given those messages to, sit up straight. We give them more towards women than we, young girls than say boys. Who carries the biggest burden of pain? Women. Other
Society.
colleagues of mine, yeah, exactly. Other colleagues have looked at neck pain to go, the most upright posture versus the most chin forward posture. And in fact, we found more neck pain in the most upright retracted posture than the most head forward posture in that cohort. When we've looked at people improving, with people chronic pain improving, we tend to see, and this is a case series that we explored, we tend to see their postures relax more. They'll be more relaxed in their postures, less guarded and tense in their postures. So we tend to say, it's not dangerous to sit straight. It's not dangerous to relax, but it's good to vary your posture. Cross your legs, sit up straight, relax, sit back, chill out, slouch, like vary your postures. But don't try and guard your body to protect it, thinking there is a posture that will protect you. And then you look at lifting posture. So that's another kind of thing. So we've got sitting posture, standing posture, which we would say variability is the key. Find postures that, break the rules, get movement back into your body. But for lifting posture, we have this view that you've got to squat with a straight back.
Right.
right? There's no evidence that stoop bending is bad for your back. There's no evidence. One of Nick Saraceni did a systematic review looking at, say, lumbar flexion. Is it a risk factor? There's literally no studies to support it. And we've just got one of our PhD students has got data showing that as people get better, they tend to be more relaxed in the way they lift. So people with chronic pain, as they improve, they start to move faster. So Ruth Chang looked at this in a group of people in the Restore trial published in JOSPT, showing that as people improve, as their people with chronic pain improve, they tend to move quicker, which makes sense. You're more confident, and that's related to less catastrophic thoughts and more confidence in the body. So again, you're not thinking about it, you move more naturally. If you're frightened, you move more protected and more guarded. And that's the same for lifting as well. Tend to see people just moving quicker, more relaxed in their body, less guarded, less protective. So again, with these messages have set up this belief, you've got to protect your vulnerable body, your vulnerable back. And so sit straight, brace your core, hold your back, squat when you lift. It's not normal. It's not natural, but it become problematic.
So it's more like a lack of movement that's causing back pain than like sitting in the same position for hours, because it's not because it's just mentally draining. If you sit for 8 hours sitting at the desk all day, it's more about your mental. Is it more about
probably physical and mental, right? Because what we know about the health of your spine is that it needs movement for its health, right? Yeah. So it doesn't, the structures around the spine don't have a great blood supply around your disc. So you need movement. So physical activity and movement are really protective of back pain. I don't know if you saw the walk back trial that, just walking every day reduces your episodes of back pain.
Absolutely.
Just that, just simple stuff.
Exactly.
So if you're someone who's sedentary and you sit all day and then you're not exercising, you're more susceptible to back pain episodes than someone who's engaging in physical activity. And so getting up, and we would say to people, in terms of what's a good chair, one that's comfortable for you, as I'd say. But don't hold a fixed posture, vary your posture, relax in the chair, get up and take regular breaks, but make sure you're engaging in regular physical activity as well, because that protects you. So those are evidence-based, perspectives.
If everyone follow the physical activity guidelines, we would be healthier, which is 2 to 3 strength training sessions per week and 150 minutes to 300 minutes of moderate cardio exercise like walking.
Yeah, you bet. Well, for everything, right? For mental health, for musculoskeletal health, for cardiovascular health. It's like everything. So these are kind of protect, there's more to it than that. There's like good sleep as well, healthy diet, engaging in good social activities. That's important for you, protecting your mental health. So there are these pillars of health that protect you across all kinds of health problems. It's not just back pain. It's just back pain is one of them. And we know that back pain is comorbid with mental health, obesity, lifestyle factors like smoking, poor sleep. Those things are all part of the mix that we have to address when we're caring for people with back pain.
I actually have a couple of clients who they are the opposite. They are too active.
Yeah.
They are in the gym 7 times a week, and then
so that's not normal either.
That's the other side
these
of the
are
horse.
2 ends of a spectrum, right? Yeah. So we would say that there are people who are and often when you explore what's happening with that person, what drives you to be pushing yourself so hard? Because often those people don't sleep well, they don't rest, they don't relax easily. So they're just on all the time and they're just constantly dry. It's a different kind of stress. So you can create what we call allostatic load, or you can stress your system through constantly engaging in physical activity and not resting sufficiently, not getting enough sleep. It becomes almost like an obsession, and that's a risk factor as well. as the other end of the spectrum, which is engaging in no physical activity, there's a sweet spot around what's ideal for your health. And so, that's why the key thing is to make sure that you have an understanding of whole health, to go, if you're engaging in lots of physical activity, are you giving yourself sufficient rest? Are you sleeping well? Are you relaxing? Do you have a way of dialing quietening your brain down? Because often people are managing their mental health through physical activity, and that's why they're obsessively exercising to manage their mental health.
I agree with that. And also, I just remembered my worst back pain episode was when they found I have an autoimmune condition, and other medical conditions, of course, affect your back
Yeah,
pain
you bet.
as well.
You bet.
Yeah.
You bet. Yep. Yep.
And
Just on that issue around there's growing evidence around chronic pain that there's this whole immune system, changes in the immune system. So if you think of your body's stress system, if you're chronically stressed, it creates all these complex changes in your immune system that may mean that you have more inflammatory, cytokines in your system because you're chronically stressed. And often that is linked to poorer mental health, not sleeping well, high levels of stress. That means you're more susceptible to pain. So these are really complex processes, and we see more and more evidence around the role of the immune system linked to chronic pain. So these are complex processes, which is why you often see fatigue and pain comorbid. You often see pain linked to other regions of pain. You see IBS, irritable bowel syndrome, linked to pain, pelvic pain linked to back pain. So all these kind of sensitizing processes are often interacting as a whole system problem, not a structure problem.
yeah, I see that now. Yeah. And what is this? So this is why we need a unique, there is no one size fits all, right? Solution.
No,
So
exactly.
this is why
Yeah.
you need individualized plan
Yeah,
for
exactly.
people who are
Yeah.
dealing with chronic, but it's
Yeah.
not one size fits all. This is going
Exactly.
to work
Yeah.
for you.
100%. Yeah. And that's where it's all gone wrong, I think, in a lot of, it's like we have these guidelines which says, well, for the majority of people, this is good, but there are always exceptions, right? So from a clinician's point of view, we have what we call a clinical reasoning framework, where we go, these are all the things that we need to consider. So someone comes in, we make sure we screen for pathology, serious pathology, specific pathology. We can do special tests for that. We then look to see what are all the other factors. How's your sleep? What's your physical activity? What are your lifestyle factors? What are you thinking? What's your emotion? How's your mental health? Like, let's look at your physical behaviors. It's all part of the clinical reasoning process. And then we go, right, what are the key drivers here? What's your social environment? What are the key drivers here and teasing that out of the patient's story so you can see the patterns. And often it's once you look at it through that lens, you'll start to see really clear patterns emerging as to the things that are driving that person's pain and disability and distress, and then target them. And so we have these kind of three pillars around sense making, of helping the person make sense of what's going on through the lens of their own story. And then the confidence building of like building the confidence back in the body in a graduated way. And then looking at other lifestyle factors and their social environment. So it's kind of like a multi-pronged approach that taps into their thoughts and their emotions, their behaviors, and their whole ecosystem of their world, to say, what are the things that are modifiable? Some things aren't modifiable. What are the things that are modifiable that can be targeted, that will dial your system down, build your confidence back in the body, help you re-engage with the things in life that you value?
Yeah, that I was going to ask you, because we talked about posture and core, which was very important myth. Can you have back pain because of weak glutes? Because there is this thing going around on social media that your back hurts because your glutes are weak. So your back muscles are overworking to compensate for your, for your back muscles. So the message
Look,
that one muscle can take over for another, and that imbalance causes pain.
yeah. So look, there is
Um,
some evidence. There is some evidence that if your legs are very weak and you're driving load from your legs, so if you've got really weak legs and you're picking something up, then you'll tend to default to use something else to use another body part. So we'll get like what's called substitution, where if there's a deficit in one muscle group, the brain goes, oh, there's no strength here, we'll use something else. But it's not a single muscle, it's usually a lower limb, for example. So for example, if you're what are the glutes good for? Well, squatting, bending, stoop lifting, that kind of stuff, right? So if you avoid bending, if you completely avoid bending, you're probably not going to be using your glutes and hamstrings. So it's kind of, they go together in a sense, but this idea that it's just the simple, there's one thing like a weak glute that's driving pain, there's just no evidence for that. But looking at the whole system is important around movement, to say, is this person moving with confidence and strength and efficiency? So that's evidence based. And if you have if you've got a lower limb that you're avoiding using and is really weak, then your body will compensate by shifting the load somewhere else. But that's around a whole system approach rather than it being a single muscle, if that makes sense.
So it cannot happen, right? So the glutes are not taking over, or the back is not taking over the glutes work.
So if you look at someone bending over, for example, and if they bend over and they lift up from their back and they don't drive the movement through the hips, the muscles that control the hips are the glutes and the hamstrings, right? So controlling that movement is a group of muscles. So we may train people to say, keep your back relaxed and drive the movement through your hips, but it's not a single muscle. It's a whole synergy of muscle. It's a pattern. So we tend to be more specific around changing movement behavior than training specific muscles. And I think back in the 90s, we were thinking muscle. The brain doesn't think muscle. The brain thinks movement. It thinks ease of movement, strength of movement, confidence with movement. So thinking around efficiency of movement is much better than thinking about a single muscle. A single muscle won't drive a system to do that.
I definitely agree with that, but I had to ask this question.
Yeah, no problem.
I actually made a post about this, that, it's physically impossible one muscle take over.
Yeah,
and I've got hit by hundreds of physiotherapists that, what am I talking about? Imagine that. So I'm going to go back with this post, Napit.
Yeah, no problem.
It was very interesting. I've got, oh my goodness, what did I do here? So with everything we've covered so far, what do you think actually needs to shift, both in the healthcare system and in how we support people living with back pain?
Yeah, so change the message, right? Understand, like, we need to upskill clinicians, number one, to make sure we screen for serious stuff, identify pathology, and then don't pathologize the majority. That's important. Change the messaging. That what we've seen in our research is that when you teach people to build a positive mindset in the body about the back, people with chronic disabled back pain, if you build a positive mindset, you build confidence back in the body, you teach them to be engaging with the things they love that they fear or avoided, and you build that confidence back and address other lifestyle factors, their pain reduces and their disability reduces and their confidence improves, right? So teaching people to protect the back does not help the back for chronic back pain. It does the opposite. And we've been doing that for years and it hasn't helped the problem. So we need to change the whole way we think about it, educate about it, and teach people how to cope with it, but also look at it as a whole health problem, not just a problem with the back. And I think often we focus on the structure of the back instead of the person's whole health. And that's to look at, are they sleeping well? What's happening in their social world? Are they got stress factors? What are their stress coping factors? Do they have other health comorbidities? Because often health is in silos. It's like, oh, I work on my mental health and now I'm working on my back. They're interconnected. You can't separate the bio and the psychosocial. It's just part of one human being. And that that you need skills to do that. And that's, part of why we set up the Evolve Pain Care Academy educational platform, was to just provide that kind of understanding, both for patients who need to educate the population as well, because this stuff doesn't make sense to patients because they've been told the other again and again and again. They've got a scan that shows that you got a disc bulge, and they're terrified about it. So it's a whole system change, which is really tough because there's lots of financial benefits keeping doing what we're doing at the moment, but it's devastating in terms of the outcomes for people living with pain.
Do you also train clinicians as well?
Yeah. Part of this platform is to train clinicians. So we've got online training, we've got free courses, and we've got online training, and then we're supporting people develop the skills to work in this way, because we've had so much interest around the world to say, how do we do this? Because it's not straightforward, it's complex, and it's a different paradigm you're working from. It's building different skills around communication, around motivational techniques, around what we call behavioral experiments, at building confidence back in the body and teaching people to be in control and in charge of their own health, rather than be dependent on me to do something to them. So it's kind of like a big mind shift around the kind of way we care for people, that the best person to be in charge is the person themselves. So we need to build their confidence, their skills, so that they're in charge of their own health. That's what good healthcare is.
So it's about helping people to feel safe and confident in their bodies again.
Yeah, and understand that when pain emerges, what are the other factors that are going on, and how can you respond differently, rather than going right down that old rabbit hole of becoming frightened or panicking, overprotecting, avoiding. That just sets up that pathway again for pain persistence and disability.
So how do we better communicate with people in pain?
Well, we've got to listen to them. We've got to validate them. We've got to hear their story, and then we've got to help make sense of their story through their experience, so that they don't feel lectured to, they don't feel stigmatized, they don't feel like we're saying it's in their head, because we know those things backfire.
I heard that many times. Pain is in the brain.
Yeah, so I think it's very unhelpful. It's something I'd never tell a patient, because it's actually not true. To say to someone, your thoughts and emotions and behaviors will influence your pain, that's evidence-based. To say someone the pain's in your head, when they go, well, I can touch it, it's bloody sore, I've got this highly sensitized structure, it hurts when I bend. Those are sensitized structures in the back that are influenced by your ecosystem of your health. That's evidence-based. People get that. They understand that. And then to make sure that it's centered around their story. So we're not just reading from a script. We're going, hey, tell me about your experience. Let's work together with you and your experience to help you make sense of it. Tell me about the things in life you want to get back to. Let's work a plan to build you back to those things. That's what person-centered care is.
But I feel like there is no time. We have 5-10 minutes visits with the doctor.
So
personally, that's me here.
Yeah, so that's crazy.
I don't know how about in Australia, but
yeah, so that's crazy. So if you think of seeing a psychologist, you don't see them for 10 minutes, do you?
No.
So why would you see a physical therapist or someone for chronic pain for 10 minutes? It doesn't make any sense. Like, that's just bad healthcare. That feeds prescriptions and referrals. That's all that does. So we're dealing with a multi-billion-dollar cost for the managing chronic back pain. We showed in the Restore trial that if you spent more time with the patient, 1 hour for an initial consult and half an hour for follow-ups, you save 5,000 Australian dollars per person across the year, because you got them back to work. So there are huge cost savings for the system to give high-value care. And we have to change the thinking around how we care for people, because 10 minutes you can't do this in 10 minutes, impossible. It's just bad care. It's called patch-up care. It doesn't work. So we have to change that. It's crazy. We don't do it for mental health. We shouldn't do it for chronic pain. It's just another chronic health condition. It's just more disabling than mental health.
I absolutely agree with that, but I don't know how is it in Australia, but if you go to physical therapy, they just show you the exercise and there is another 10, 15 people in the group and they don't
Yeah. Look,
really
we got to change it.
have time.
So yeah.
They don't have
So
time. And it's
so
nobody's fault. This is the
the system.
system. This is the
Yeah, yeah.
system.
We have to change the system because the system is not working. So there's no point perpetuating a system that doesn't work. That's costing, health funds billions of dollars. The system has to change, and we've seen that in our research. Like to deliver this kind of care takes time, but you save a lot of money for ongoing care, less ongoing care, and getting people back into, to work. So it saves money. We've got to think of it not around a unit of care, around a package of care. So that's a different way of thinking about care. And health systems understand that. They're starting to come on board to say, can you provide this care? Because we don't know, we're out of options. So that's what has to change.
And what do clinicians need to start doing differently to actually support recovery, not just manage symptoms?
Upskilling. That's why we set up this educational platform, because they need knowledge, they need confidence, they need skills. Well, knowledge, skills, and confidence. So that's a mindset shift. And from our research, we've heard this from the clinicians who have gone through the training. They've told us that this is a behavior change process for them, of challenging their own beliefs, their own clinical behaviors. Need to change to provide this kind of care, but we need health systems to support it because it's not working. What we're doing at the moment is not working well.
I agree with that absolutely. Now, there was a recent article in the New York Times that reviewed 56 treatments for back pain. I shared that with you, and concluded that most of them don't help much. And there was a big headline.
Yeah.
Nothing helps much for chronic back pain, which was shocking. And from your perspective, why do you think so many treatments fall short? And what should people really focusing on instead?
Yeah, so, it's true. Most treatments for chronic back pain don't work, and they don't work well at all. That's what was unique about the Restore trial, which we have published in the Lancet. We showed long-term sustained effects with this approach that lasted out to 12 months, and we've got a 3-year follow-up that will be published probably in the next couple of months, showing that those effects are lasting out to 3 years. That's unusual in our space. So what it highlights is that what we're doing at the moment doesn't work well. That's what that paper highlights. So we need different approaches. We need a different way of looking at the problem, because we can't keep doing the same thing expecting the same result. That's all that paper showed. It's just like what we're doing is not working. We need to do something different.
So in the paper, there was taking a pill, chiropractic adjustments, manual therapy.
Yep.
So there was only single. It wasn't a whole person approach, right?
No, of course. But that's the problem with a lot of research as well. It's tests. It's like a lot of RCTs have come from a drug paradigm of like testing a tablet. It's
can I
translate
that to the list?
Care. Yeah.
So the listeners are RCTs, randomized control trials, right?
Yep.
Because
exactly.
They don't understand it. RCTs, randomized control trials. So there was this New York Times article, and they did this randomized control trial, and they said that nothing works for chronic back pain, but they didn't look at the whole picture.
No,
they were looking at little bits.
Yeah, just the other thing around that paper, it was compared to placebo. So if you think of you can't compare, it's hard to compare CFT to placebo because it's a complex intervention.
CFT is cognitive functional therapy.
Exactly, yeah. So you can compare a spinal manipulation to a sham manipulation, right? there was actually a paper published in BJSM comparing cognitive functional therapy to detuned ultrasound and chatting to the patient, showing that there were really big differences with the cognitive functional therapy intervention in favor of better outcomes. So, but the paper that you're talking about was looking at placebo. So it's really hard to get a true placebo. It's like not a pill, like there's a sugar tablet versus an active tablet. Really hard to get that for complex interventions. You can't really do it. You can do an alternative intervention, but you can't really do I'm pretending to do, person-centered care, lifestyle advice. You can't pretend to do that. That doesn't make any sense. So there's an issue around the research design of those projects. They're testing individual treatments, and we know they don't work. So we just got to stop doing them.
Imagine I was reading that and they didn't give hope to people. Imagine if you have chronic back pain and you're reading that article, and there is no hope for me. That's the last thing we should be telling.
So that's why we've put up this educational platform, because there's a whole area there for patients to say there is a lot of hope for people with chronic pain, but it's not chasing down manipulation, needling, single interventions. It's about a package of care. It's about a broader understanding. It's about a whole body, whole person approach. That's what we've got to be advocating, and stop doing the other stuff, because the other stuff hasn't worked and it won't work.
Exactly. Now, Pete, tell us about, I know you and your team just launched is it Evolve Pain Care?
Yeah, it's called Evolve Pain Care Academy. Yeah. So look, we've been working on this for 2 years, and we wanted to create something that we thought was really cool. That was a place for patients to go, a place for clinicians to go, free resources, a free course, but also bigger, like a training program as well. So we got literally like a 3-day online, which we think is really cool, with real patients, real interactions, looking at how they hit the roadblocks, taking the patient through their whole journey, talking through, reflecting, clinical reasoning. So that's our approach, and it's a social enterprise. So any profits are to support the mission. It's a non-profit organization, to try and help clinicians and people with pain change their understanding and build their confidence to make a difference. That's what we welcome people to look at it, and they can access it. They can give us feedback on it. The resources for patients are co-designed, so we worked with patients to design them, so it's written in their language. The resources for clinicians have been road tested through clinical trials, so we're delivering material that has been research tested as well. So it's not just something we've worked out. It's been a huge amount of volume of research and clinical discovery that has occurred over a period of time. So that's what we've done to try and shift the dial to support people with pain, and also the clinical community to change how they care for people with pain.
Now, the online course, is it only for clinicians?
Well, interesting. I had a patient contact me. He said, "Hey, I did your free course and I scored 100%, because there are quizzes involved as well." And he's going, "It was so cool because it was everything you've taught me made so much sense." So it was designed for clinicians, but actually patients are doing it as well, because they're learning about it as well. So it wasn't intended for patients, but they're doing it. That's super cool.
I love it. I love it. I am going to share your website in the description for everyone who's listening.
Yeah,
so we are definitely going to share that. Now, Pete, I work with many clients who have a history of trauma, and we actually touched based on trauma and chronic pain. So whether it's childhood adversity, emotional stress, or more recent events, and I actually noticed that for many of them, pain seems to stick around longer or feel more intense.
Yeah,
what are your thoughts? So what are your thoughts on the connection between trauma and chronic pain?
Well, there's really good evidence for it. So we've been involved in research that looks at early childhood trauma or stress, so poor family functioning or significant stress events in a child's early life, increases your susceptibility for chronic pain as a young person, as a young adult. So that's about the developing nervous system. We know that early life trauma is a predictor for poorer mental health, disruptions to sleep. This is again the emergence of the developing nervous system in a young person increases your vulnerability to pain and to stress and to other health comorbidities. So it's something we have to, if, like this young lady who I saw recently who said, my pain started when I was 10. Like that's absolute signal that you got to explore. So what was happening in your early life? And this whole story of early life adversity came out around. And then of course the question is, um, have you got support for that? And she had. She'd got a lot of support for that. But this pain thing was just something that was just really, she couldn't connect with that. But it just is, it creates a vulnerability. We can't change someone's history, but it helps for them to understand why they're more susceptible through that lens, but also build support capacity and resilience around how they can address their vulnerabilities to, really care for their health, their mental health, their physical health, their sleep, their social engagements. Those things are protective, but those people carry a greater vulnerability and they carry a greater health burden.
I am going to share something very personal. So my dad has had chronic back pain forever. But since I do what I do, I know chronic pain, and we've been talking about this for a very long time. He actually saw his dad dying when he was 8 years old, and he remembers everything.
Mm.
And in front of him,
Mm.
his dad died. And he actually took me last year to the house where, everything happened. And he remembers the furniture, how everything happened. And so he has chronic pain and he has insomnia for 60 years because
Yeah.
it's happened at 3 a.m.
Yep.
But
Yep.
we've been talking about it, so he's
Yeah.
understanding it more. But
Yeah.
nobody helped me. He's 69.
Yeah. Yeah.
No
We
one
said it.
ever told him
Yeah.
that
Yeah.
this can be a contributing factor
Yeah.
for
Yeah.
your chronic pain, and no one
It's so common.
ever. So I just wanted
Yeah.
to share this because
Yeah.
hopefully someone who's
Yeah.
listening
Yeah.
can
And
relate to this.
I think what you're highlighting is key is that, we that's about relationship building too and trust, because people won't share stuff with you if there's no time, if there's no sense of trust, if they don't perceive that. We check people out. Are you trustworthy for me to share these deep things with you? And so for some of our patients, we don't hear about the early trauma until we've really built trust with them, because often it's a break in trust. So if you've been, say sexually abused as a child, there's a huge issue around trust, and that sense of vulnerability around trust is key, and that's why building trust, the therapeutic alliance, is so important. And that's, for me as a physiotherapist, I can't, I'm not going to treat the trauma, but it may be a mechanism of getting that person to get psychological support to deal with trauma that's never been addressed. That's key, and to know that they can see, have an understanding of why they're experiencing what they're experiencing through that lens, and then look to addressing it. That's important.
And I don't think that the healthcare system looks at people with chronic pain or chronic back pain. What happened? Did you have any trauma?
Yeah, we have
They
to.
don't.
We
I
have
think
to.
this is such an important
Mm.
piece. I actually
Yeah, it
just
is.
came across with a systematic review
Mm.
from last
Yeah, that's
year.
right. That's right. Yeah.
I just read that,
Yeah.
and this is
Yeah.
why I reached out and I asked you last
Yeah.
week. Did you
Yeah.
read that
Yeah. Yeah.
research paper? I'm trying to
Yeah.
get the lady to do the
Yeah.
podcast with me. Hopefully, she will.
Yeah. Yeah.
Because that's such an important
Yeah.
piece. And I just
Yeah,
put
it
the
is.
puzzle together with
Yeah.
my dad as well. And with
Yeah.
so many of my clients
Yeah.
who's been, I have
Absolutely.
clients sexually abused,
Yeah. Yeah.
narcissistic abuse,
Yeah. Exactly.
physical, emotional. And I just put the
Yeah.
picture together and I shared this in my group with my people, and
Yeah.
everyone opened up.
Yeah.
Everyone opened up.
Yeah.
about
Yeah.
their trauma
Yeah.
and
Yeah.
sharing more and feeling
Yeah.
safe in the environment
Yeah.
to talk about.
Exactly.
But nobody did.
Yeah.
Nobody
Well,
talk
but
about trauma
that's an
and
that's
chronic
another
back
failure
pain.
of our health system, because we know, that's about the developing nervous system. It's it's embedded. That stuff's embedded. It changes our physiology. It influences how we respond to stress, our sense of vulnerability, our threat responses, all informed by that. So it's something we absolutely have to be alert to and explore. And um, you know, it may be an opportunity to cross refer for that person, but also it may just be an understanding, a broader understanding of, hey, this gives me a deeper understanding of the journey that I've walked through.
How do you treat people? I mean, talk to people who are really fearful of movement, but you know they need to move.
Yeah,
Do you
so
get a
that's where we
psychologist or?
no, like that's cognitive functional therapy is really good at that. So it's around relaxation, deep, because when you're frightened, your sympathetic nervous system hyper aroused. So breath work, slow relaxation, gradual building back movement, confidence, and then grading it back into function. So, the graded exposure with control. So the person always feels in control. You always regulate their stress responses. It's the key for getting people back to engage in scary things. So the only thing that overcomes fear is to build confidence to do the thing that you're frightened of. So you have to do exposure work, but exposure can backfire if the person gets a flare up or if they have a panic attack. It will make their fear greater. So you've got to control the stress response, control their anxiety and fear as you do the exposure, so that they don't ramp up in that process. And that's what we train clinicians to do. So part of the Evolve program, you'll see graded exposure, and you need a lot of trust. So we kind of see it a bit like if you're rock climbing and the person's frightened of heights, you have to start very gently and slowly. You got to make sure they feel confident with you as an instructor. You have them on the rope. You're checking in with them all the time, that they feel like they're in control. If they feel out of control, then their anxiety and fear will spike. And that's where we back it off. So it's very person-centered. It's very respectful. It's very kind. It's scary, but we're always making sure the patient feels in control when we take them through that process.
Have you ever made a mistake that you had a
You
patient
bet.
and they had a
Yeah, of
flare up?
course. Of course. Yeah, of course. And, yeah, that's life. And I think the key thing is if the patient knows you really deeply care, they'll come back and they'll tell you. And then you can modify what you're doing. Uh, I think the risk for doing exposure work is that it becomes our agenda, not the patient's agenda. If it's like, I'm going to tell you how to do it, and I'm going to tell you what to do, that can massively backfire because you didn't read the person in the first place. But if you read people well, you can sense their anxiety and their fear. You're talking them through it and you're checking in with them. Are you okay with this? And, let's take you through this process. And it's always aligned to your goals. So we're really clear on, like, this is getting you back to stuff in life you value. That's the direction of this journey. It's not about my agenda, it's about your agenda. So that's so important, because we're only ever driving them back to doing the stuff they love.
Yep. I made a mistake too in
And
January with a
time.
lady.
Take time. Yeah.
Yep.
Yeah. Look,
I made this.
that's part of the clinical journey, right? Is like, as long as people know that, and I always say to people, hey, if you're concerned or you have a flare up, just email me. Just let me know. That's part of the journey. We expect flare ups as well. That's part of the journey. How you navigate them is part of that journey.
Back pain healing is not linear. It's kind of like
Exactly right. Yeah. So we need to understand that. Yeah,
like
absolutely.
Like a roller coaster.
Yep.
Now, Pete,
100% is. It is.
Have you ever had back pain?
Oh, heaps. So I had an injury when I was a young physio, skiing, where I thought I'd broken my back, and it became quite chronic and disabling. And I realized I was doing all this stuff. I was overprotecting my body. The pain was spreading. I was getting worried. I was reducing my levels of physical activity. I'm a really active guy. I'm not naturally a frightened person, and it got me into I got caught in a real cycle. And one day someone said to me, "Hey, Pete, you're holding yourself very awkwardly." And I looked in the mirror, I'm going, "What am I doing?" And I realized I'd subconsciously massively overprotected my body. And I basically trained myself to just learn to relax my body and get moving, and it subsided. I've come off a mountain bike and fractured transverse processes. I've had a disc prolapse before. I've had back spasms through mountain biking when I was fatigued. I've had transverse myelitis, which was horrible. That was terrible pain. I've had heaps of pain in my body. But, I think the key thing, it's been so helpful as a clinician to experience various kinds of back pain, but fundamentally to have this belief the body's ability to recover is amazing. So for me, pain in my body, which I would probably have every day, is just a signal to me to go, hey, Peter, you're getting enough sleep, you're taking it easier, you're getting enough physical activity, are you learning to switch your brain off, you're managing your diet. Like, they're the things that's the message for me around pain in my body, is around, it's not a sense of threat. It's more about my whole health. And that's something that I've deeply learned in my own personal journey, that the body's ability to recover is extraordinary. And I think that's the bit that we really latch onto.
So if, for example, someone just woke up with terrible back pain, what are the questions they should ask themselves?
Yeah, what's happening in your life? So if it's come on for no reason, like, look back in the last couple of months. Is there something that's changed? Has your sleep been different? Have you had more stress in your life? How's your mood been? Have you been engaging in physical activity? Have you had how's your whole health? Because usually it's around whole health, and it may be different factors. Have you been, doing a whole bunch of physical loading of your back that you weren't accustomed to? It's like, you don't run, or you run a half marathon, like, you're going to get knee pain. Like, just piecing together what's changed is what I would say. Like, look back in your life and go, what are the factors that have changed in your life? And usually then you start to see stuff. That's what I would say. And if there's nothing you can see that makes sense, go and see a healthcare practitioner who you trust, who you know is going to consider your whole health.
Now, can you tell the listeners when they know if they are in good hands with the clinician?
Yeah. Has the person listened to your story? Have they validated you? Have they explored, have they screened for serious stuff? Have they explained things? Have they thoroughly examined you? Have they explained things to you in a way that makes sense? Have they given you strategies to manage your pain? Have they given you options around what you want? Have they checked in your goals and around your expectations? Have they talked to you about your future trajectories? Have they reassured your concerns? That's what good care does. It puts you back in the driver's seat. It gives you a clear understanding. It maps a path that's aligned to your goals. If you're not getting that, go somewhere else. If they overpromise, they promise to fix you by you coming back 3 times a week for 12 months, go somewhere else. It's bullshit. If they scan your back and tell you're out of place and they tell you need a lot of treatment, get out of there. It's not evidence-based. If they frighten you unnecessarily, go and see someone else.
If they refer you to a specialist straight away?
Look, if you've got cauda equina syndrome, or you've got an infection, absolutely. You've got a fracture, absolutely. But if you don't have those things, it doesn't make sense. Unless it's a specialist who takes a whole person approach. But if it's to go and jump on a spinal fusion because you got a degenerate disc, that doesn't make any sense to me. There's no good evidence for that.
If someone is listening right now and feels stuck, defeated, or scared about their back pain, what are the 3 things you'd want them to walk away with today?
Well, I would say go and check out our website, actually, and listen to the stories of people. So we've got a whole bunch of stories of people with different ages who have all talked about their journey to recovery from chronic pain. Those are not our stories, they're their stories. And they're really helpful because people can often see elements of themselves in that journey. We've also got infographics around back facts, around the evidence around what's going on in your body, what the best treatments are based on evidence. Go and look at that stuff and then self-reflect on your own life and go, what are the things that are making sense to you? That's what I would encourage them to do.
And can you give the listeners 3 tips when they are, recovering or they want to recover from back pain? Any 3 tips?
Yeah, keep active, keep moving, build your confidence back in the body. The back is designed to move in every direction, to bend, extend, twist, the side bend, relaxation techniques. Make sure you get good sleep. Do the stuff that you love. Engage in the physical activity you're likely to do for life. They are the kind of key things. If you have loss of fear or confidence in your body, build it up slowly. Start in simple, less loaded positions, gentle movements. Check in with your breath, because your breath will often link to your stress system, your levels of tension. So if diaphragmatic breathing, slow your breathing down, relax your body, get movement back. That's the key pillars for just building your confidence back in your body.
Great. Thank you.
Pleasure.
I really enjoyed our conversation, Pete. Yeah. Thank you, Pete. And thank you so much for listening and tuning into the Back to Movement podcast. This is all for this episode, folks, and we see you next time.
Thank you.